Hi, good evening.
Good evening.
I'm Yonatan, Butbul from Israel. I'm working in Haifa in the north of Israel.
And I'm Tillmann, Kallinich. I'm working at the Charité in Berlin.
That's a challenge one. I think it's linked, but it's not all the time very clear. We have a paper that we published in around 300 patients with PFAPA, and about 20% of them were diagnosed with FMF as well. And the big question is whether they're really having FMF or not, and only 30% of them have really a full genetic, like they were homozygote for some of the mutation. And the rest have only one mutation. So the big question is whether it's really a different disease or it's just the symptoms that are overlap.
And anyway, it's really hard to diagnose both diseases in children. Especially the FMF sometimes occurs with only a few symptoms, only with fever, for example, in the very young child. And the PFAPA syndrome not only has the classical symptoms like the Pharyngitis and the lymphadenopathy and the Aphthous ulcers, but also can present with abdominal pain, with myalgias. So there's also a strong overlap, and it's really difficult to differentiate them in young children.
But we did find that in our cohort, the things that were more common in the FMF patient were myalgia and abdominal pain. And we defined like severe abdominal pain and mild abdominal pain. So the severe abdominal pain and myalgia were more common, and arthralgia were more common in the FMF PFAPA overlap patient compared to the pure PFAPA patient. So they might be. And I think another thing that we have to discuss is about the colchicine response to treatment.
Yes, that's striking. Both diseases respond to colchicine, and so we think there's in both diseases neutrophils are playing a major role. But as all know, or we all observe, there's a very good response in FMF. It's the gold standard to treat FMF. But we also use colchicine in children who have very frequent attacks and need a lot of steroids just to spare the steroids over time.
And the thing is colchicine is working like in about 50% of the kids with PFAPA. And sometimes even when they have overlap symptoms, so they may have the symptoms of PFAPA continuous, and maybe they respond like in the FMF symptoms. So it's sometimes really difficult. Even the response to treatment, it doesn't really all the time help you to differentiate between the two diseases. So it's still a challenge. And I think we have to find maybe more lab things that will help you to differentiate maybe more serum amyloid A to find out in episode whether it's helping to differentiate between episode of PFAPA and FMF, or whether it's really a different disease or not.
That's true, and even the gold standard, the genetic analysis, doesn't help us really, because we do have the children who has just one mutation within the MEFV gene and suffering of FMF, but we also see an increase of heterozygous MEFV carrier in the PFAPA cohorts. So if we have a heterozygous mutation in a child, it either might have Familial Mediterranean Fever or PFAPA. So this is a dilemma for us.
In terms of ethnicity, we find that 90% of our PFAPA patients were from Mediterranean ancestry, compared to around 50% in the general population, which means that even PFAPA, that is not a monogenic disease, we find a difference in ethnicity. So it's striking. I think we don't know enough, and we need to look for maybe more basic science in order to differentiate between the two diseases. And another striking thing that even in mevalonic kinase disease, there are reported of PFAPA in patients with mevalonic kinase. So it's not the only autoinflammatory disease that have symptoms of PFAPA that are overlapped.
But it shows we have a lot of work to do. We can't do the work alone, so we have really to cooperate and to set up large registries and really go into the details of the disease clinically and in terms of basic mechanism underlying the disease.